All right, future doctors want to really dive deep into some MCCQE content.
Yeah.
Welcome to the Deep Dive, the show that takes, those really dense medical topics
Yeah.
and turns them into something you can actually, remember when you're sitting there in the exam.
Yeah, exactly.
I'm Harvey, your guide, and fellow MCCQE prepper.
And I'm Donna, here to help break down all those major concepts the MCCQE loves to throw your way.
Today we're tackling a topic that's, well, it's a classic, and a bit of a chameleon, really. We're talking about acute abdomen.
It's a good one.
We'll be using a trusted source, Stat Pearls, just to make sure our information is rock solid.
Always got to have a good source.
Yeah, and remember, this is just for, educational purposes only, not medical advice.
Yeah.
Always consult with a qualified healthcare professional, for any health concerns.
Absolutely.
All right, so let's jump right in.
Okay.
Picture this. You're in the ER, a patient comes in with sudden severe abdominal pain. What's going through your mind? What's the first thing you absolutely need to rule out?
Well, that sudden onset of pain, that's the hallmark of an acute abdomen.
Okay.
It's a signal that something is wrong and needs urgent attention.
Right.
Could be anything from inflammation to, a life-threatening condition.
Yeah.
And that's why it's so important to take it very seriously.
Absolutely. That's what makes it so tricky, right? The symptoms can be so varied. It's like solving a medical mystery,
Exactly. And just like a good detective,
Yeah.
you need to start with the basics. A really thorough history and physical exam. That's where you'll gather the crucial clues.
Okay, so let's put on our detective hats then. What are some of those key questions we need to ask to really get to the bottom of this?
Well, first we want to understand the pain itself.
Okay.
Where exactly is it? When did it start? How severe is it on a scale of, 1 to 10? Is it constant or does it come and go? Those kinds of things.
Right, because sometimes even like mild discomfort can actually signal something more serious.
Right.
Like leaking abdominal aortic aneurysm, which could be mimicking, renal colic or even back pain. Talk about a curveball.
Yeah. It's why it's so important to dig deeper. You've got to ask about associated symptoms. Are they nauseous, vomiting, fever? Are there changes in bowel habits?
So we've got the patient story. Now it's time for the physical exam.
Yeah.
I'd imagine the location of the pain is a pretty huge clue.
It can be, but it's not always as straightforward as it seems.
Right.
Remember, free air in the abdomen, that can lead to more diffuse pain, which makes it even harder to pinpoint the source.
Ah, so we can't just rely on that point and shoot method, huh?
Nope, not always.
Got to use our brains.
You got to pay attention to other signs as well, like are the bowel sounds absent? Could point to peritonitis.
Right.
Or if we see rebound tenderness and guarding, that's another big red flag, could be peritoneal irritation.
Okay, so we've got a detailed history. We've done a thorough physical. We're starting to, narrow down those possibilities.
Yeah.
Now, what are some of the usual suspects in this medical mystery?
Well, think of the most common culprits. Appendicitis, cholecystitis, pancreatitis, diverticulitis. These are like the bread and butter of acute abdomen cases, especially for med students prepping for the MCCQE.
They got to know these for sure.
Yeah.
All right, let's break those down a little bit more, starting with appendicitis. What's that classic presentation?
So typically you'll see the pain start around the belly button and then kind of migrate over to the right lower quadrant.
Okay.
But gotta remember, not every case is a textbook example.
Yeah, real life is always a little messier.
Exactly.
What about cholecystitis? That's a gallbladder issue. Right?
Exactly. And with cholecystitis, you often see pain in the upper right abdomen, sometimes radiating to the right shoulder.
Okay.
Key clue here. The pain is often triggered or worsened by fatty meals.
Makes sense. So what about pancreatitis? I always picture this one as being super painful.
Oh, yeah, you're not wrong. It typically presents as this really severe band-like pain in the upper abdomen, often radiates to the back as well.
Oof. Yeah, that's not going to be fun. And finally, diverticulitis.
That usually causes pain in the lower left abdomen.
Okay.
It's important to note that age can be a big factor in all of this. Older patients, they're more prone to conditions like diverticulitis, cholecystitis, and those scary vascular emergencies we talked about.
Right. Those can be really serious. So we need to adjust our thinking based on the patient's age, too.
Absolutely. It's all about putting the pieces of the puzzle together. The history, the physical exam findings, the patient's demographics. And don't forget, sometimes that nervous system throws a wrench in things with referred pain.
Refer pain, yeah. That's where the location of the pain doesn't actually match the source of the problem, right? Like a trick play by the nervous system.
Exactly. It all comes down to how our nerves are wired, basically. We have two types. visceral and somatic nerves.
Okay.
Visceral, those give us that deep, kind of dull, poorly localized pain, while somatic nerves are responsible for that sharper, more pinpointed pain.
So visceral's more like something's wrong in there somewhere, and somatic is like, ouch, it hurts right here.
Exactly. And sometimes those nerve fibers from different areas, they converge on the same spinal cord segment,
Okay.
which explains why you might have pain in one spot, but the problem is actually somewhere else entirely.
Like with cholecystitis causing pain in the right shoulder blade.
Exactly.
That's wild. It really highlights how important it is to have like a broad differential diagnosis.
Oh, absolutely. Beyond those common causes we discussed, there's a whole host of other things that can cause acute abdomen. Vascular events like mesenteric ischemia
Right.
or a ruptured abdominal aortic aneurysm.
Those are big ones.
Yeah, those are game changers.
For sure.
And we can't forget about gynecologic causes like ectopic pregnancy or ovarian torsion.
Oh, good point.
Yeah, so it's not just about the digestive system. We need to think about all the possible players in the abdomen.
Yeah, we got to think big picture here.
Absolutely, and that's why recognizing those early, non-specific symptoms is so crucial. Missing a developing abdominal catastrophe, well, that could have devastating consequences. We got to be on our toes.
For sure.
Yeah.
All right, so we've got a patient with a suspected acute abdomen. We've gathered all the clues from the history and physical exam. We're starting to formulate our differential. What's the next step in this medical mystery?
Well, now we need to move, and we need to move quickly and decisively.
Okay.
The key is rapid evaluation and treatment,
All right.
which often happens, simultaneously.
So we need to be efficient and effective. What are the immediate actions we should take?
So if the patient is showing signs of shock, think hypotension, tachycardia, that screams fluid resuscitation. Got to get those IVs going, restore circulating volume ASAP.
Yeah, absolutely. That could indicate blood loss or dehydration, which obviously need immediate attention. What about antibiotics? Do those come into play early on?
Absolutely. If there's any suspicion of infection, peritonitis, or sepsis, we don't wait for a definitive diagnosis. We hit it hard and fast with broad-spectrum antibiotics.
So it's like a preemptive strike to prevent things from getting worse.
Exactly.
Yeah.
And of course, we need to manage pain and nausea effectively. Not only is it the humane thing to do, but it also helps us do a better job of actually evaluating the patient.
Because pain and discomfort can kind of cloud the clinical picture, right? Makes it harder to get a clear history and do a proper physical exam.
Precisely.
Yeah.
And if there's even a whiff of a surgical emergency, we got to loop in a surgeon right away.
Okay.
Even before, extensive testing.
Yeah, makes sense. Time is of the essence in those situations. We don't want to delay any potentially life-saving interventions.
Exactly. Now, alongside stabilizing the patient, we also need to figure out the root cause of this whole problem. That's where our trusty diagnostic tools come in.
Okay, let's talk tools. What are the go-to tests for an acute abdomen?
Blood work is always the starting point. We'll order a CBC, a comprehensive metabolic panel, lipase levels to assess pancreatic function, lactate if we're worried about sepsis or mesenteric ischemia.
Okay, and imaging. I imagine that plays a pretty huge role in these cases.
It's crucial. Bedside ultrasound can be our secret weapon, It can quickly show us things like cholecystitis,
Yeah.
hydronephrosis, bleeding in the abdomen, or even a worrisome abdominal aortic aneurysm. It's fast, it's portable.
Right.
It can give us vital information right there at the bedside.
So ultrasound is often the first imaging test we reach for.
It often is, especially when we need those answers fast. But CT scans are also essential. They provide much more detail, can often clinch the diagnosis. We often use IV contrast with a CT just to get even clearer pictures.
What about MRI? I feel like that's becoming more common these days.
MRI is great for some things, but in these acute abdomen cases, time is really our enemy. MRI takes longer to perform. When we're dealing with a potentially unstable patient, we need answers quickly.
So ultrasound and CT are the real workhorses in acute abdomen.
They really are. And remember, it's not just about ordering the tests. It's also about communicating effectively with the radiologist. Give them a clear, detailed history, and it helps them to interpret the images accurately, provide the best possible guidance.
Yeah, it's all about teamwork, as always.
Absolutely. Managing acute abdomen effectively requires a village, or in this case, a well-coordinated medical team. You've got the general surgeon, maybe an OB/GYN, maybe a vascular surgeon, depending on what we're dealing with, nurses, pharmacists, and of course the radiologist, all working together.
Wow, it really does take a village to tackle these complex cases.
It really does. And the outlook or, prognosis can vary greatly depending on the underlying cause and how quickly we can intervene.
Right, that makes sense. I mean, a ruptured appendix is going to have a very different prognosis than, say, simple constipation.
Exactly. And even within the same condition, there can be a wide range of outcomes. For example, someone with uncomplicated appendicitis treated promptly, they're likely to make a full recovery. But if that appendix ruptures and causes widespread infection, well, the prognosis is much more guarded.
So there are so many factors at play. The condition itself, the severity, the patient's overall health. It's like a delicate balancing act.
You got it. And that's why we can't afford to delay in these cases. The sooner we identify the problem and initiate treatment, the better the chances of a positive outcome.
All right, so we've navigated the initial evaluation and management of acute abdomen. We've identified the usual suspects, discussed the importance of a thorough history and physical, and we've highlighted the role of those key diagnostic tools.
Yeah,
But there's still so much more to cover, right?
there is. Stay tuned for part 2, where we delve even deeper into the nuances of managing acute abdomen and discuss those tricky situations that can really test your clinical judgment.
We'll be back soon to crack open the next chapter of this medical mystery. See you then.
Welcome back, future doctors. We're picking up right where we left off in our deep dive into the acute abdomen. That medical mystery that keeps us all on our toes.
Last time, we talked about those red flags. Sudden onset of pain, associated symptoms, and the importance of that thorough history and physical exam.
Right. Got to cover all the bases.
Yeah.
And we even started to unveil some of the usual suspects, right, behind this abdominal drama: appendicitis, cholecystitis, pancreatitis, diverticulitis. Those are definitely the ones to keep in your MCCQE arsenal.
Oh, for sure. Those are the classics.
Absolutely.
We also touched on those crucial diagnostic tools like blood work, ultrasound, CT scans, all those things that help us to get a clearer picture of what's happening inside.
Right, because once we have a better idea of what we're dealing with, then we can really tailor our treatment accordingly. But I remember when I was a student, calling for a surgical consult felt like a really big deal. Like, am I really ready to bring in the big guns? When is the right time to make that call? Yeah, it's a common feeling. And trust me, no one expects a medical student to know everything. But in these acute abdomen cases, time is critical. If there's even a hint of a surgical emergency, it's always better to err on the side of caution. Involve a surgeon early on.
So what are some of those red flags that should make us grab the phone and, page the surgical team?
Well, if the patient is hemodynamically unstable, think wonky blood pressure, heart rate.
Yeah.
That's a major red flag right there.
Right, because that screams something serious, like major blood loss or sepsis, not something we want to mess around with.
Exactly. Other signs that should make you think surgical consult stat.
Okay.
Severe unrelenting pain that just won't quit despite pain meds, signs of peritonitis, like that rebound tenderness and guarding that we talked about, a rigid board-like abdomen.
Okay, those paint a pretty clear picture of a surgical situation. But what if the initial exam isn't so clear-cut?
Even then, if the patient's condition is going downhill, or you have a strong gut feeling that something surgical is brewing, it's best to get a surgeon involved sooner rather than later.
Yeah, makes sense. Always better to have that surgical expertise available, even if it turns out to be a non-surgical issue. 2 heads are better than 1, especially when you're dealing with something as complex as an acute abdomen.
Absolutely. And remember, it's all about teamwork. Having that surgical perspective can be invaluable, even if it's just for reassurance.
Yeah. So while we're waiting for the surgeon to arrive, are there any general management principles we can apply to most acute abdomen cases, regardless of the underlying cause?
Definitely. No matter what's causing the acute abdomen, the name of the game is stabilization. We need to support the patient while we work towards a diagnosis and definitive treatment.
Okay, that makes sense. So what are the key steps in the stabilization process?
Well, as we mentioned earlier, aggressive fluid resuscitation is crucial for anyone showing signs of shock. Restore that circulating volume, make sure those vital organs are getting the oxygen they need.
And what about antibiotics? When do those come into play?
If there's even a suspicion of infection, peritonitis, perforation, or sepsis, we don't wait around. We hit it hard and fast with broad-spectrum antibiotics, even before we have a definitive diagnosis.
So it's like a preemptive strike against potential infection without taking any chances.
Exactly. And of course, pain management is paramount. We use a combination of medications, often including opioids, to keep the patient comfortable.
Makes sense. I mean, pain can really ramp up that stress response and make everything worse. Plus, if the patient's more comfortable, it's easier for us to do our job and figure out what's going on.
Precisely. Controlling that pain helps us get a clearer clinical picture. And let's not forget about nausea and vomiting. Those are common companions of an acute abdomen. Antiemetics are our friends here.
Right, because persistent vomiting, that can lead to dehydration and electrolyte imbalances, which just adds another layer of complexity to the situation.
Exactly. It's all about providing supportive care while we're working towards a diagnosis.
So it's a balancing act, right? Manage the symptoms, stabilize the patient, and simultaneously hunt for the culprit behind this abdominal mystery. Sounds like a real challenge.
It can be, and while we're juggling all of this, we're also constantly monitoring the patient's vital signs, urine output, and their overall clinical status.
Looking for any signs of improvement or deterioration, making sure we're not missing anything crucial.
Precisely. And remember, communication is key throughout this whole process. We need to keep the patient and their family informed about what's happening, what we're doing, and what to expect.
It's not just about treating the physical condition. It's also about addressing the patient's anxiety and fears, providing reassurance and support during a potentially scary time.
Absolutely. Now let's shift gears a bit and talk about some of those diagnostic challenges that can pop up with acute abdomen cases, because sometimes it's not as straightforward as we'd like it to be.
Okay, what makes these cases so tricky sometimes?
Yeah.
I'm all ears for any tips that can help us avoid those diagnostic pitfalls.
Well, for starters, the symptoms can be frustratingly vague, especially in the early stages. A patient might just complain of some mild abdominal discomfort, and it's up to us to figure out if it's something benign or the beginning of something more sinister.
So it's like being a detective, but with a medical twist. We're sifting through the clues, looking for those subtle hints that can point us in the right direction.
You got it. And then you have situations where a patient might have a whole host of other medical problems, making it even harder to isolate the cause of the abdominal pain.
Comorbidities. Those can really muddy the waters, can't they?
They sure can. And then there are age-related considerations. Infants and young children, they can't always tell us what's wrong, and older adults might present atypically, meaning their symptoms don't always match those classic textbook descriptions.
So we need to be extra vigilant in those age groups, especially when it comes to acute abdomen cases. No room for assumptions.
Exactly. And then there are those head-scratching cases where even with all the tests and exams in the world, the diagnosis remains elusive.
What happens then? Do we just throw our hands up in defeat?
Not at all. Sometimes the best approach is watchful waiting. We monitor the patient closely, repeat exams and tests as needed, and see how things unfold.
So it's a process of elimination, observation, and careful reassessment. Sometimes patience is the best medicine, right?
It can be. And of course, there are those rare cases where surgery is necessary to both diagnose and treat the problem.
So exploratory surgery is still on the table, even in this era of advanced imaging.
It is, but it's usually a last resort. We try to exhaust all other options before going down that road.
Speaking of evolving approaches, you mentioned earlier that the way we manage acute abdomen has changed over time. Can you tell us a bit more about that evolution?
Sure. In the past, the mantra was often operate first, ask questions later. If someone presented with signs of an acute abdomen, they were often whisked off to the operating room without much delay.
Wow, that's a pretty aggressive approach. What prompted that kind of thinking?
Well, back then, our diagnostic tools were much more limited. We didn't have the luxury of ultrasound or CT scans readily available, so surgeons often had to rely on their clinical judgment and operate to both diagnose and treat the problem.
So it was a necessity, driven by the limitations of the time. But now, with all the technological advancements we have, we can be a bit more discerning, right?
Exactly. With the advent of sophisticated imaging techniques, we can often pinpoint the cause of the problem without immediately resorting to surgery, especially if the condition isn't immediately life-threatening.
So it's a shift from cut first, ask questions later to a more measured, image-guided approach. I imagine that's a welcome change for patients, too.
Absolutely. It means fewer unnecessary surgeries and potentially faster recoveries. It's a win-win situation.
So what you're saying is technology has played a huge role in revolutionizing the way we manage acute abdomen. It's given us more options and helped us move towards a more conservative, patient-centered approach.
Exactly. And the evolution continues. New imaging techniques and minimally invasive surgical procedures are constantly emerging, further improving the way we diagnose and treat these conditions. It's an exciting time to be in medicine.
It really is. Now, before we wrap up this part of our deep dive, let's talk about prognosis. What can you tell us about the outlook for patients with an acute abdomen? Is it always doom and gloom, or is there hope for a happy ending?
Well, as you might imagine, the prognosis can vary quite a bit depending on the underlying cause and a whole host of other factors.
Right. A ruptured appendix is going to have a different outlook than, like, a simple case of constipation.
Exactly. And even within the same condition, outcomes can differ widely. Someone with uncomplicated appendicitis treated promptly will likely make a full recovery. But if that appendix ruptures and causes widespread infection, the prognosis becomes much more guarded.
So it's a complex interplay of factors: the underlying condition, the severity, how quickly we can intervene, and the patient's overall health.
You got it. That's why it's so crucial to individualize care and tailor that management plan to each patient's unique circumstances. There's no one-size-fits-all approach when it comes to an acute abdomen.
Okay, that makes sense. So we've talked about the evaluation, the management, the challenges, the evolution of our approach, and the prognosis of acute abdomen. What else should we cover before we wrap up this deep dive?
Well, one aspect that's often overlooked, especially in the heat of the moment, is the importance of post-operative care. Because getting through surgery, that's just one hurdle. There's a whole recovery process ahead.
Right, surgery is just the beginning. What happens after the patient leaves the operating room is crucial for ensuring a smooth recovery and minimizing complications.
Exactly. And that recovery process can be just as demanding as the initial intervention. So let's spend a few minutes talking about what post-operative care entails and why it's so important.
Sounds good. Where should we start? What are the key elements of a successful postoperative recovery?
Well, one of the most important things is pain management. After surgery, patients will inevitably experience some degree of pain, and it's our job to ensure that it's adequately controlled.
Because uncontrolled pain can delay healing, increase the risk of complications, and make the whole recovery process much more difficult for the patient.
Absolutely. And remember, pain is subjective. What one person considers tolerable, another might find excruciating. So we need to individualize pain management plans and listen to our patients.
So it's not a one-size-fits-all approach. We need to tailor the pain management strategy to each patient's individual needs and preferences.
Exactly. And it's not just about medications either. We also encourage non-pharmacological pain relief techniques like deep breathing exercises, relaxation techniques, even music therapy.
Those can be surprisingly effective, can't they? Sometimes the simplest interventions can make a big difference.
They really can. And then there's the issue of wound care. Depending on the type of surgery, patients might have a small incision that just needs to be kept clean and dry, or they might have a larger, more complex wound that requires regular dressings.
And infection is always a concern, right? Especially with abdominal surgeries.
It is. So we educate patients on how to care for their wounds properly and what signs of infection to watch out for.
Like redness, swelling, drainage, or increasing pain at the incision site. Those are all red flags that shouldn't be ignored.
Exactly. And we also emphasize the importance of hand washing and general hygiene to prevent the spread of germs.
It's all about minimizing the risk of complications and promoting optimal healing.
Precisely. And another key aspect of postoperative care is early mobilization.
Meaning getting patients up and moving as soon as it's safe to do so. I know it can be tempting to just let them rest and recover in bed, but that can actually do more harm than good.
You're right. Bed rest can lead to a whole host of problems like blood clots, muscle weakness, and pneumonia. So we encourage patients to start walking and doing gentle exercises as soon as their surgeon gives them the green light.
It's amazing how something as simple as walking can make such a difference in recovery. It gets the blood flowing, prevents those nasty clots, and helps patients regain their strength and mobility faster.
Exactly. And then there's the nutritional aspect of postoperative care. Depending on the surgery, patients might have dietary restrictions for a while.
Like avoiding certain foods or sticking to a liquid diet until their digestive system is back up and running.
Right. And as they start to heal, we gradually reintroduce solid foods, making sure they're getting adequate nutrition to support their recovery.
Because proper nutrition is the fuel that powers healing. It's essential for wound repair, immune function, and overall well-being.
Absolutely. But postoperative care isn't just about the physical aspects. We also need to address the psychological and emotional aspects of recovery. Having surgery, especially emergency surgery, can be a traumatic experience for patients.
So it's not just about fixing the physical problem. It's also about acknowledging the emotional impact and providing support during what can be a very stressful and uncertain time.
Exactly. And that's where the role of a compassionate and supportive healthcare team becomes even more crucial. We need to listen to our patients, address their fears and concerns, and provide them with the resources they need to cope.
So we're not just doctors, we're also counselors, cheerleaders, and advocates for our patients.
Precisely. And that might involve connecting them with support groups, therapists, or other healthcare professionals who can provide specialized care.
So postoperative care is really a holistic process that encompasses the physical, emotional, and psychosocial needs of the patient. It's about seeing the whole person and providing comprehensive care that extends beyond the operating room.
Exactly. And it's an ongoing process that continues long after the patient leaves the hospital. We need to equip them with the knowledge and support they need to navigate the recovery process and regain their health and well-being.
Okay, I think we've covered a lot of ground on postoperative care. Any other final thoughts on acute abdomen before we wrap up this deep dive?
Well, one thing I want to reiterate is that acute abdomen is not a diagnosis in itself. It's a syndrome, a collection of symptoms that can be caused by a wide range of conditions.
So it's like a puzzle that we have to solve, using all the tools at our disposal: the history, the physical exam, the diagnostic test, and our clinical judgment.
Exactly. And it's a puzzle that requires a team effort to solve. From the initial evaluation to the postoperative care, managing acute abdomen effectively requires collaboration, communication, and a shared commitment to providing the best possible care for our patients.
And it's a process that demands both knowledge and compassion. We need to be skilled clinicians, but we also need to be empathetic listeners and advocates for our patients.
Well said. I think that's a great note to end on.
I agree. So, to wrap up this part of our deep dive, let's distill a few key takeaways for our future doctors. What are the main points you want them to remember?
First and foremost, acute abdomen is a medical emergency that demands prompt recognition and treatment. Don't delay seeking care if you or someone you know experiences sudden, severe abdominal pain. Time is of the essence.
That's a crucial message. Early intervention can make all the difference.
Absolutely. Second, the evaluation of acute abdomen involves a thorough history and physical exam, along with appropriate diagnostic tests, including blood work, imaging studies, and possibly other specialized tests.
So it's a systematic approach to gathering information and narrowing down the possibilities.
Exactly. And third, the management of an acute abdomen is always tailored to the individual patient, taking into account the underlying cause, the severity of the illness, and the patient's overall health and preferences.
So it's a collaborative decision-making process that involves the patient, the primary care physician, and the surgeon.
Precisely. Now, I know we've thrown a lot of information at you, but remember, this is just an overview. There's a whole universe of knowledge out there about acute abdomen, and we encourage you to continue exploring this fascinating and challenging topic.
Dive deeper, read those research articles, attend those conferences, and never stop learning.
Absolutely. And as always, if you have any questions or concerns, don't hesitate to consult a qualified healthcare professional.
That's right. We're here to guide you through the complexities of medical knowledge, but we're not a substitute for personalized medical advice.
Okay, I think that's a wrap for part 2 of our deep dive into acute abdomen. We've covered a lot of ground, but there's still more to come.
Join us for part 3, where we'll explore some of the latest advancements in acute abdomen management and discuss those tricky cases that can really test your clinical skills.
Until then, keep those brains buzzing and those stethoscopes handy.
See you next time. Welcome back to the deep dive. We've journeyed through those, twists and turns of the acute abdomen, from those first kind of alarming symptoms to the intricacies of diagnosis and management.
Yeah, we've covered a lot of ground.
We have. We've tackled those common culprits like, appendicitis and cholecystitis.
Right.
Explored the power of diagnostic tools like ultrasound and CT.
Yeah.
We even delved into the nuances of postoperative care.
Yeah, we did.
But the learning, it never stops.
Never stops, especially in a field like medicine. It's constantly evolving.
It is. So how do we stay, on top of all the latest advancements? It feels like every day there's a new study or guideline being published.
It can definitely feel overwhelming, but there are some great resources out there to help keep us informed.
Okay.
Peer-reviewed journals, they're a goldmine of information. And medical conferences offer a chance to really hear from experts and connect with colleagues, bounce ideas off each other.
And let's not forget those online databases.
Yeah.
And continuing medical education courses. Those can be lifesavers, especially when you're short on time, but you still want to stay up to date,
Absolutely. But it's not just about absorbing information passively. We need to be critical thinkers, carefully evaluating the evidence, applying it to our own practice.
So it's about being discerning consumers of medical knowledge, always kind of questioning, always looking for that best evidence to guide our decisions.
Exactly. Because at the end of the day, it's all about providing the best possible care for our patients. And speaking of patient care, let's talk about the importance of individualized care.
Oh, that's a huge one, especially with something as complex as an acute abdomen.
It is.
It's about recognizing that, no two patients are exactly alike. And what works for one, well, why not work for another?
Exactly.
We need to really tailor our approach to each patient's unique, needs and circumstances.
Absolutely. It's about seeing the whole person, not just the disease. We need to consider their age, their medical history, their lifestyle, their preferences, even their values when we're developing a treatment plan.
It's about having those open and honest conversations,
Right.
understanding their fears, their concerns,
Mm-hmm.
really empowering them to be active participants, in their own care.
Exactly. And you know what? When patients feel heard, when they feel respected, when they understand their options and feel involved in the decision-making process, outcomes tend to be better.
It's that powerful combination of medical expertise and genuine human connection.
Couldn't have said it better myself.
Okay, so we've talked about staying up to date, individualized care. Anything else you want to touch on before we wrap things up?
Oh yeah, there's one more thing that I think is super crucial, especially in those really fast-paced, high-pressure, acute abdomen situations.
Okay, hit me.
Communication.
Ah, yes, that's a big one.
Huge. Communication between healthcare providers, communication with patients and their families. It's the glue that holds everything together.
It really is. It's about clear, concise, you know, information exchange, active listening, acknowledging concerns, building trust. It's the foundation of safe and effective care.
And when communication breaks down, that's when things can go wrong. Misunderstandings happen, mistakes are made, patients can feel lost and confused.
Absolutely. So let's make a pact to prioritize communication, both with our colleagues and with our patients.
Yeah.
It's the key to building those strong therapeutic relationships and achieving, the best possible outcomes.
Okay, I think we've covered a lot of ground in this deep dive into the acute abdomen. We've explored those complexities, the challenges, and the ever-evolving nature of this fascinating area of medicine.
We talked about the importance of staying informed, providing individualized care, and really fostering, open and honest communication. It's been quite a journey.
It really has. So let's leave our listeners with a few key takeaways, just some things to ponder as they continue their medical journeys.
What are your top 3 pearls of wisdom for our future doctors out there?
Okay, number 1. Acute abdomen is a medical emergency that demands swift action. Don't delay seeking care. If you experience or if someone experiences sudden severe abdominal pain, time is of the essence.
Couldn't agree more. Early intervention can literally be life-saving.
Exactly. Number 2, diagnosing an acute abdomen requires a systematic approach, like we've been talking about, that combines a thorough history and physical exam with the appropriate diagnostic tests. It's like piecing together a puzzle.
And number 3?
The management of an acute abdomen should always, always be tailored to the individual patient, taking into account their specific needs, preferences, and medical circumstances. It's about collaborating, communicating, and providing compassionate, patient-centered care.
Those are 3 excellent takeaways to remember.
Yeah.
But as we always say, this deep dive is just the starting point.
It is.
The world of acute abdomen is vast, it's ever-changing, and we encourage you to continue exploring, questioning, and learning.
Never stop learning.
Never stop learning.
There's always more to discover, for sure.
And remember, if you ever encounter a challenging case or you have those lingering questions, don't hesitate to reach out to a trusted mentor, a colleague. We're all in this together.
We are.
That's the beauty of medicine, right? It's a collaborative field where we can learn from each other and support each other along the way.
Exactly.
Well, thanks for joining us on this deep dive into the acute abdomen.
Yeah, thanks for listening, everyone.
We hope you found it informative and engaging.
We've been our best.
Until next time, keep those brains buzzing and those stethoscopes ready.
And remember.
And remember, you've got this.
You got this.